sort of see as the participants are slowly logging in. It's an honor of me to host and co-chair this webinar. We will be talking about pediatric deformity. And with me, I have not only two excellent surgeons, but two good friends that are as passionate to pediatric spinal deformity. We have Feroz Mianji and Stéphane Parent, a little Canadian flavor this evening. These are disclosures, and this is the content validation, essentially saying that we are independent nonprofit surgical specialty society, that AO is more than keen on providing knowledge and know-how. We do not endorse or promote any products. This will be important. You'll be receiving in about 24 hours a login that you'll be able to obtain your CME credits. Obviously, we asked for you to keep your mics muted and your cameras off. If you have any questions, it's really through the Q&A box. We'll be answering those on the fly, and that we'll have some ability to sort of try to answer some questions at the end. Essentially, what we're planning to provide to you tonight is really an overview of sort of giving you a bit of broad-based concepts of pediatric spinal deformities, sort of focusing on their natural history, global surgical management, sort of paying a special attention to sagittal alignment in posterior spinal fusions, indication of anterior vertebral body, as well as the natural progression of untreated adolescent idiopathic scoliosis into adulthood. At the end of the seminar, you'll be able to define the pediatric spinal deformities, their clinical significance, provide you with some foundational concept of surgical management in these different types of spinal deformities, understand the key difference between addressing AIS with posterior spinal fusion versus anterior vertebral bodies, looking at biomechanical concepts and surgical approach, and really describe the natural history of progression of untreated adolescent idiopathic scoliosis in adulthood. So I'm, as I stated, Jean Ouellet, and I'll be giving you that first half, or hopefully not first half, first 20 minutes of the talk, because I'm sure that my co-faculty will be harping at me. So here we go. How to approach pediatric spinal deformities. These are my disclosures. As stated, these are the objectives. Pediatric spinal deformities come in all shapes and forms, and that the management of these spinal deformities vary considerably. Now, I'll just show you. So there's 4 patients that essentially have spinal deformities. You have a young girl who's mainly complaining of mild postural asymmetry, and she presents and complains very differently than the other child who's 16, who has cerebral palsy, and he no longer can sit in his wheelchair. He has pain, and he seems to be always falling off the outside of his chair. Compared to the 9-day-old who has not passed stool since birth, and is obviously in chest x-ray has some abnormalities in respect to his overall shape of his spine. And that child is very different than this 13-year-old who complains of shortness of breath. So all these patients have scoliosis, but they have very different diagnoses and such as very different management. And so if you look at spinal deformities, you can sort of break them down into 5 broad categories. There's essentially idiopathic scoliosis, you have your congenital scoliosis, you have your neuromusculars, really are 2 subcategories looking at spastic or sort of neural component versus muscular abnormalities. I like to also broaden this other categories, which is mesenchymals, which is really the building blocks of the skeletal construct. And that, so you're thinking about osteogenesis imperfecta, Marfan's, Ehlers-Danlos, they're building blocks of the spine, leads to spinal deformity. And then finally, you have actually genetic predisposition of having spinal deformities. And these I sort of lump into syndromics. And then so you have Down syndrome or Prader-Willi or even Cri-du-Chat. These are all abnormalities that generate deformities, and that being able to classify them allows you to associate or sort of identify the associated pathologies. Essentially, how do you do that is really doing a thorough history and physical. So being able to identify the root cause of deformity is crucial, because sometimes there's hidden disasters. So this young girl that seems to have a fairly benign right-sided curve, as you examine her, she has a neurocutaneous lesion that really illustrates there's a hidden disaster underneath. And so she has actually a diastole diabetelia, which is a tethered cord, and that if you hadn't picked that up, well, then if you had embarked on surgery without really looking at it, you could have got into trouble. There's another boy, a 14-year-old, who has a left-sided curves. And right off the bat, alarms would be sort of ringing, saying this is not the classic idiopathic scoliosis. When you examine him, he has bilateral cavus feet, he has calf atrophy, and lo and behold, this boy has Charcot-Marie-Tooth disease. Hence, this boy has a neuromuscular disease, and that he has an increased risk of malignant hyperthermia. He has prolonged risk of response to neuromuscular blocking. So again, your surgical management may be fraught with complications if you don't identify that preoperatively. So here's a young patient, I was telling you, 9 days old, and has this spinal abnormality. And that not only are the vertebrae abnormal, but the ribs are abnormal. And then so often you have these associated congenital malformations. And if you look at the underlying pathologies, 25% of them will have urological abnormalities, so single kidneys. 10% will have cardiac malformations. 25% will have neurological, so intradural pathologies. And then you have these polymalformations or syndromes that you could have esophageal atrasia, vacral, chest wall abnormalities. But not only do you need to do a thorough physical exam for these congenital malformations, but you really need to work them up appropriately to look at for these congenital malformations. So all these children that have a congenital malformation, you should be getting kidney, like abdominal ultrasounds, looking for kidney abnormalities, getting an echo of the heart, seeing if they have any cardiac malformations, and obviously an MRI scan to assess the spinal cord. Now, if you look at the broad categories also progress differently, and that knowing the natural history of the individual curve that presents to you in clinic will determine the timing of the surgery and possible the overall management. So again, if you think about curve progressions really dependent on growth, then it's critical to identify where your patient is on this growth chart. As you know, growth is essentially in a bimodal peaks. They're essentially from the age of 0 to 5, you have a lot of growth, and the growth is sort of stable between 5 and 10, and then you start getting that adolescent peak growth, and that obviously the growth will predict your curve progression. So this is a sort of a classic type of Cobb prediction. So if you have a child that's immature, that could be graded with a Risser grade, 0-1, that has a small curve, their propensity to progress is about 22 degrees. If their Risser is much more advanced, so Risser 2 to 4, and they have a small curve, their risk of progression is almost 0. Quite different that if you have a larger curve in an immature child, that child has about a 70% chance of getting progressing. There's different clues that you could look at for maturity. People look at pelvis, such as Risser sign. You could elbow, looking at the olecranon ossification and the morphology of it. And recently, there's a Sanders score that gives you a good sense of where they are in their overall growth. Again, the broad category is essentially a curve of 0 to 20 you tend to observe. Curves that are between 20 and 50 are braced. Curves that are above than 50, they tend to warrant surgery. Now, the importance of secondary growth spurts is really more related to your adolescent idiopathic scoliosis. And again, looking at the maturity, essentially looking at Rissers, 0 Rissers are really pre-peak growth velocity. And that throughout this period, you could look at your triradiates to see if they're closing. And again, you're still pre-peak growth. Looking at your elbow, you're looking at the ossification of your elbow, and that your growth plate for your olecranon actually closes at your peak growth. So these, again, are all clues as to where your child is in respect to that peak growth velocity. And then essentially after that peak growth velocity, then you fall into different Risser 1, 2s, and 3s. And that obviously this sort of is useful for your effective bracing. Any child that falls within that Risser smaller than Risser 2s are obviously at high risk of progression, and you should be initiating bracing. Again, the value of your growth chart can again be crucial as you're planning to do your growth modulation. And essentially, balancing your curve magnitude and your residual growth is sort of where one optimizes that treatment with the growth modulation. Now, the value of your growth curve also is very specific for early onset scoliosis, and that first growth period is critical as you try to develop one, spinal length, but also lung development. And again, so having a good sense of what are your segments are supposed to be grown. So if you look at T1 to T12, as your child, you tend to come out and you have about 10 centimeters of thoracic height. And if you look at that growth, you essentially have a total of 18 centimeters that's going to grow across that from the age of 0 to 16. And as we know that essentially the goal for maximizing lung function is to try to maintain that spinal length that is roughly about 20 centimeters. So obviously, if you're intervening at any point in that you're inhibiting that growth, then knowing where you're at, how much growth there's left, obviously dictate how you're going to want to manage these children with this early onset scoliosis. And when you look at congenital scoliosis, what is the risk of progression? Well, again, it really depends on the morphology of the spinal deformity. And that the congenital scoliosis are sort of subcategorized in two broad categories: failure of formation, which is essentially a hemivertebra, while in contrast, a failure of segmentation, where there's actually a bar. So one is that there's an added growth on one of the side, essentially the convexity, compared to that the bar is actually a loss of growth. And when you categorize or sort of look at your congenital scoliosis, one can have sort of two shapes or two. You could have a very focal deformity, and that you could address that in a certain fashion, compared to if you have a global deformity, we have multiple spinal deformities and possibly associated rib abnormalities. So as you start drilling down into the morphology of those deformities, essentially, depending on the morphology, you have a risk of progression. So a fully segmented hemivertebra with a contralateral bar has the highest risk of curve progression. That's about 6 to 9 degrees per year. Compared to the opposite, if you have an intercalated hemivertebra, that's about 1 degree a year. Your neuromuscular scoliosis are the ones that progress the most, and these are the sort of hypotonic, sort of Duchenne muscular dystrophies that can progress 6 degrees a year, compared to your cerebral palsy. Spastic type of curve can progress 20 degrees a year. Now, when you look at your spinal deformities, you really have to try to understand what deformity you're really dealing with. So this child that has a severe spinal deformity, when you look at it closely, a patient has a severe pelvic obliquity, but he also has that rotational deformity that as the spine progresses, the lateral x-ray is actually an AP of his spine because there's such amount of rotational deformity. And that one of the particularities of neuromuscular scoliosis is really a kyphoscoliotic deformity. And that's really in contrast to idiopathic scoliosis, where you get this apical lordosis. So as you're managing these deformities, you really have to think about what is the deformities at hand. And as you look at these x-rays, you really see that the apex of the coronal deformity, there's an associated apical lordosis. And that's what they talk about. So Atlas idiopathic scoliosis is really a lordoscoliosis. The next question is, how do you address, or when do you proceed to surgery with these spinal deformities? Well, it's really essentially is when conservative management has not changed the natural history of the deformity. There's this young child on the left that had a 30-degree deformity at the age of 4. We did serial casting, and then 4 years later, no longer had scoliosis. Now, that's very different than this other little 3-year-old that, despite serial casting and bracing, the curve progressed. So therefore, essentially, the mainstay of treatment for early onset scoliosis is serial casting. And that once you've lost the control of that curve, you should probably dictate surgical management. And that observation and conservative treatment sometimes actually is at risk. And this is really that explanation. Now, if we look at some of the surgical plans, and again, trying to sort of wrap this up and trying to figure out how do you go ahead and manage these patients, this young patient has essentially an aesthetic deformity, has a mild trunk shift, and has relatively pulmonary compromise. The goal is really to stop the progression, correct the malalignment, and fuse the least amount of segments. So this was at an era where anterior spinal fusions were performed. I still like to do these for these short thoracolumbar apical fusions that you have very short segments that are fused, getting maximal correction and good functional outcomes. Very different type of child. So this boy essentially has myelomeningocele, has a severe gibbous, can no longer sit in his chair. His parents have cut out these back out of his wheelchair just to try to get him to sit. So radical deformity often requires radical surgery. So here essentially one undertakes a kyphectomy in order to resect the gibbous, allow the patient to have some tissue to be able to close over that gibbous, being able to balance the spine. There's another child that's 6-week-old, essentially has a chest wall abnormalities. And again, trying to define what this deformity is, you really have to try to in order to manage this, is you really need to identify the true problem at hand. So essentially, not only does the patient has congenital deformities, a patient of the spine, but patient really has a bar that's localized in his chest. And essentially, Bob Campbell described this as thoracic insufficiency syndrome, is that the inability of the chest to grow, and that the propensity for further spinal deformities increase, and not only because of the congenital hemivertebras, but he has a fixed tether. So the management of this is really to do a thoracostomy, expanding that chest wall, and then using a rib base, spine base, you go ahead and continue to distract that chest wall to maximize that lung volume. And that essentially 13 years later, we ended up proceeding to posterior spinal fusion with a reasonable chest length and deformity. So here's a last child. So here's a boy who has a myomeningeal, essentially is unable to sit independently, always leaning because of his severe pelvic obliquity. We ended up doing a lumbar pelvic fusion and essentially a growing rod construct, allowing him to continue to grow above. So essentially the broad principle for management of pediatric spinal deformities are really, one is define the deformity, identify the type and the underlying diagnosis. And essentially this will allow you to address those. Figuring out the true etiology behind the abnormality will allow you to avoid and identify associated pathologies, minimizing your perioperative complications. To know and respect these comorbidities will allow the patients to have a better outcome. At the base, you need to understand the natural history of each spinal deformities. As they're all different, they will progress differently, and therefore your management has to change. Assess the risk of progression. Intervene if you think you could alter the natural history. So from a surgical point of view, the goal is to prevent further progression of the deformity, achieve sagittal and coronal balance, correct the sagittal and coronal alignment, fuse the least number of segments, allow the spinal height to maintain lung function, with all of this with the least risk of spinal cord. Well, thank you so much. This is just a little sort of pause so that I could sort of breathe a bit and see if we get a few answers to come out. Essentially, welcome to the AO Spine North America webinars. There's a few coming up of interest of biomechanics of the spine, which is March 19th, May 21st, and managing perioperative optimization. Got MIS in August, and you'll be able to look at this on online courses. Thank you for your attention, and then I'll pass it on to Stefan.
Yes. I did try to answer one of the questions, but I think Feroz is actually doing this. I think you need to stop sharing. There you go. So I was tasked to give you a talk on the surgical management and try to concentrate on posterior spinal fusion and anterior vertebral body tethering. I'm Stéphane Parent. I'm based in Montreal. Hello or good night, everyone. These are my disclosures. So the principles of deformity surgery, a little bit like Jean just said, is to prevent progression of deformity. We're trying to do this into a single surgical event. Sometimes we need to do more than one, but typically we try to do this in a single surgical event. And we're trying to address the three planes while doing that correction. And remembering that this hypokyphosis and thoracic lordosis that we see in the deformity, we're getting pretty good at correcting the coronal and the axial balance, but the sagittal plane remains probably the most challenging portion of the treatment. So that's why part of my talk will concentrate on this, how we can restore this. The goal of surgery is to improve spinal balance and the alignment and prevent further progression. It's usually indication is usually based on the curve magnitude, so usually above 40 to 50 degrees, the clinical deformity, the sclerotic to maturity, and then we'll go on into when we think that anterior vertebral body tethering is applicable, the curve pattern, and the risk of progression. So a patient that comes in that's immature with a bigger curve is at a higher risk of progressing than a more mature patient with a smaller curve. So these need to be taken into account when you're making that decision to go on to surgery. Fusion up to now remains a standard for the treatment of scoliosis. Most of us agree today that the posterior spinal fusion is usually the standard treatment. There was a pendulum swing at some point for open anterior and tricuspid anterior instrumentation and fusion, but these have have less are less popular nowadays. But there is some because we're doing more VBTs now. People have addressed more deformities from the front now, so this is starting to pick up again. But the real standard right now is that I would say that maybe 90% of surgical correction, at least in the US and in Canada or North America, is done to a posterior spinal fusion. Some areas in Europe are still doing anterior fusions on a more regular basis. Right. So what is really bad about spinal fusions? If you look at the long-term effect, it's really the longer your fusion is, the more stress you put on the adjacent unfused segment. So when looking at the selective fusions, we could see that the lower you were going down, the more impact that had on that distal motion. So that motion that you were still maintaining was divided by less levels. So if you stopped at L1 versus L4, your total motion seemed to be similar, but your actual motion per level was higher. So that puts a lot more stress on these patients. The indications for surgical treatment, again, during growth, patients with curves over 45 to 50, a progressive thoracic deformity, trunk imbalance, and failed brace treatment. After the end of growth, you typically look for a curve over 50 degrees, progressive deformity, and intractable pain. The current trends in surgery is try to fuse as short as possible, but relying on a lot of instrumentation to get to that goal. There's increasing posterior versus decreasing anterior procedures. Segmental instrumentation gives you very good correction. Thoracic pedicle screws are now state-of-the-art, and thoracoscopic procedures have a redefined role. We'll go into this as we go through the cases here. So example of a case done all posterior, just a posterior-based instrumentation trying to minimize the numbers of levels, good kyphosis restoration. You can notice here that this patient had almost had a hypokyphosis, not total lordosis, but you can see that the restoration in kyphosis and the sagittal plane is really nice. We're trying to get a balanced spine, avoid fusing unnecessary levels, and providing long-term pain relief, and then preventing cardiopulmonary decompensation. This can be also done from the front. You're trying to save levels here. We stopped at L3 on this deformity, and this can be done through an anterior thoracoabdominal approach, but again, very elegantly done through the front. So how do we restore kyphosis in surgical patients? So there's a couple surgical pearls that I wanted to give you. So again, we're trying to improve sagittal balance. We're trying to personalize the correction goals, trying to determine what the actual kyphosis for a specific patient needs to be. So you're going to look at their pelvic incidence, try to rely on how much lordosis they have, and then try to build on this lordosis and try to restore your kyphosis to improve your long-term outcomes. And again, restoring kyphosis to correct the hypokyphosis and lordosis is really addressing that sagittal plane. So today I'm less concerned about the coronal plane. I try to get them as straight as possible, but I'm really more concerned about the sagittal plane and trying to restore the exact or the appropriate amount of kyphosis when I do the surgery. So how do we obtain kyphosis surgically? There's different ways, but one of the first ways you can work on that's pretty easy to get is just positioning your patient on the table properly, trying to put the thoracic bolster or bump at the right position so you maximize kyphosis generation just by lying them prone. Then wide posterior releases are commonly used. Pontiosteotomies, I'll show you how we do this. And then anterior release through a thoracoscopic approach or an open approach will give you the best results because you'll try to shorten the front of the spine and extending the posterior part of the spine when you're doing this kyphosis generation. And in the end, also different raw materials can give you or can help you get to your goals. This is my current surgical technique. I will do my wide posterior releases and my pontes and do my screw placement. So I typically do my screw placement first. and then do my wide posterior releases and Pontes after that. And then you can see that you go through your both sides of your facet joints, get your lamina completely down, and then really exposed all the way out to your facets laterally. So you want to make sure that this is completely free, and you can actually close these pontiostiomes afterwards. So here nowadays I do this with a high speed. And I don't want to use the term because it's a commercial name, but it's a very rapidly oscillating saw that you can actually go and do your cut, and then but you can do this also with a rongeur or a Keras. And then all the way out to your foramen. You want to be able to get all the way out there, and also remove your yellow ligament. So if you do this, you can get fairly good correction in the sagittal plane and the coronal plane. It gives you a good restoration. And again, on this patient, the patient had a pelvic incidence of 54 degrees. So you need to restore enough lordosis, but also enough kyphosis above it, so that you actually are getting a good correction in both planes. This is another case where you can see that this patient has actually extra lordosis in the thoracic spine. So the lordosis actually ends somewhere around T1. So that patient was all about lordosis. You can see this in the 3D reconstruction here, that the maximal plane of the thoracic curve is actually pushed forward. So that's actually a bad sign. So this is an indication for me where I will go do a anterior release through a T-scope release. So we don't do a lot of instrumentation and fusion anymore. We'll talk about what we do where we use it for VBT, but for releases, it's actually something that I still go to. And my curve size have gone down over the years. I do now consider patients with smaller curves, but when they have a mismatch in the sagittal plane, I'll probably try to use a anterior release through the scope. It gives you very good access to the anterior part of the spine. You can actually shorten the front of the spine, and you can get a very good help, at least a very good kyphosis generation when you're adding this to your regular posterior spinal fusion. You get a very good exposure, trying to protect the vessels here on the bottom of the spine, but you get a very good visualization of the vertebral bodies and the discs. And after you have done your disc release, you can get actually a very good disc release and discectomy through the scope, and without having necessarily to open chest and do this with an open approach. So typically this is the type of results we can get. You can see that although we didn't create massive correction of the kyphosis, you can see that there's actually kyphosis restoration, where this patient had a thoracic lordosis up to T1 prior to surgery. So you can actually have a good sense that this patient is actually better. And then on the 3D reconstruction, you can see that this plane of maximal curvature. Sorry for people who are colorblind, but you can see that the thoracic curve was really pushed out of the way here. You can see that it now rotated back in the sagittal plane, and now it's almost midline. So you can see that there's actually good kyphosis restoration. And again, pre to post-op, by adding this anterior procedure is actually very helpful and into restoring kyphosis. So what are the other things that we can look at? I mean, there are different ways of making better rod shapes. We can plan osteotomies better. Bigger rods can maybe help you get to your result where you want this. We've been working closely with different industries to try to simulate surgery ahead of time, to try to see if there's new materials that we could use. But this is all upcoming, but there are ways now that you can actually simulate the surgery prior to doing the surgery, which can help you making that decision ahead of time. So today, I'm not going to go into too much of the simulation, but certainly we can better appreciate what the pre-op planning can help you make in terms of decisions for your surgery. These are different. This is a typical differential rod bend that I would get on my patient. So you can see that the rod on this one is much more has much more kyphosis built in. That would be my concave rod, and then you flat the second one. The second one is a little bit flatter. That would be my convex rod. But that helps me both get to the result where I can derotate, but also generate enough kyphosis on that concave side when I'm putting the first rod in. Again, a good example here of kyphosis restoration through a posterior spinal fusion with an anterior release in this patient. Again, another case where we did a posterior spinal fusion only. We did have a good correction in the coronal plane, but maybe not perfect. But you can see that I was much more happier with the thoracic profile in this patient. And again, we're trying to adjust what the pelvic incidence looks like, trying to get a good lumbar lordosis so that you have a match here, but then you have a good thoracic kyphosis that's generated above. So again, focusing on the sagittal plane and trying to restore this patient's more normal or more adequate anatomy to their pelvic incidence. So in summary, kyphosis should be personalized to each individual anatomy. It's important to consider pelvic parameters pre-op and trying to find if there's any mismatch between the thoracic kyphosis and then planning your surgery accordingly. Different surgical techniques can increase kyphosis locally, and anterior release can really help you shorten the front of the spine, while your osteotomies will help extend the back of the spine. Rod shapes will help you getting your kyphosis back, and then that rod material selection, knowing which type of material you can use between titanium, cobalt chrome, stainless steel, and more recent materials will help you maximize that correction. So now on to growth modulation. So I write there, I did write there that it's a new approach. It's an approach that we've been practicing for the past 10 years. Feroz has done the first case in Canada. I was short time after that. But the idea is that if you look at your AIS algorithms, that before we would only look at observation, bracing, and then surgery. But then the surgery was the posterior spinal fusion. Now we've been trying to find this midpoint between a failed bracing and a surgery, but maybe intervene a little bit earlier, so that the common natural history before was that you would have a progression and eventually you would have a posterior spinal fusion. But then if you could intervene a little bit better, but grasp that growth and use it to correct the deformity, maybe you would get a better correction at that time. So, and this is all based on work that has been done in different labs. Our lab really looked at the uretero-Volkmann principle, where you have asymmetric pressures on the growth plates, creating asymmetric growth through the uretero-Volkmann principle, and then having progression of deformity. And then how Ian Stokes taught us is that you get a vicious circle. So we are understanding this now better, and we're trying to predict how a patient's deformity will progress. But if you're able to come in with a fusionless treatment, trying to stop the growth on the convex side, maybe you can change this and make it more symmetric when you are with the patient, and then trying to have more normal growth as you go. So really, this has been done through different years of experimentation in animals, where we were able to induce scoliosis in different models. So Peter Newton worked really hard on this, and Feroz and I trained with him. So we did some of these surgeries. But the idea now is that you can have this young patient that came in with a deformity, juvenile scoliosis, open triareates with a high risk of progression, which I would have treated normally with the anterior and posterior spinal fusion. But then what we do here is that we expose, so on your right, there's the lung that's deflated, and then the top part is your head, and then you're coming in through ports that you can actually implant a staple. This is old material that was pre the FDA approval. Now Feroz has worked on a new device where there's more appropriate material and screws, but we would then You can see on the screen that you can actually see how your screw goes in the vertebral body, and then you can align it, and then you can see after we implant our screws, we get a good view both in the coronal and the sagittal plane to make sure that those screws are anterior to the spinal canal, but we're able to have a good visualization, and then trying to line up those screws as much as possible in the sagittal plane. And then on the next one, you'll see that we'll be able to come in with a cord, a tether, and then attach it from the top. There are new instruments now to tighten or put tension on the system. This is how I did it before. So you preload, you set screw, and then you come in and you try to, there's now ways that you can actually come in line and grasp that tether and pull on it. But back then we would twist the cable on itself and make sure that we would get appropriate tensioning. So you can see we'll jump over the instrument there, but you'll see how much tension we can actually apply just by turning that tether. And then we can actually correct quite a bit on the table. So we're trying to apply as much tension as possible, especially on the apex. And then you can see how much correction we got there. And then you get an initial correction on the table, some additional progression afterwards, but then you get a lot of correction if the patient has still some growth. So this is a case example, initial correction. You can see that this patient had maybe 40% of correction, but a lot of growth with open triareates. And then you can see at 6 months, minimal correction, but coming back at 24 months, this patient actually did correct quite a bit. So this is, to give you an example, I still tell my patients that this is experimental. The current challenges is that we may have too much growth. So if you pick a patient that has too small a curve, and that was really the issue when we first started doing this, people were trying to get a lot of correction in smaller curves. So overcorrection was a bigger concern. But if you don't have enough growth for the type of deformity that you have, then maybe undercorrection is going to be a concern. Wet levels to instrument and how much tension to apply is something that we all struggle with. So this is probably, you'll see this. These are my current indications. I still do a lot of Lenke's, thoracic, 1As, 1Bs, and 1Cs. 40 to 70, I'll give you my optimal indications afterwards. Premenarchal, I really think that this is a growth guided procedure, so not something that you do in mature patients. I prefer to have open triads and Risser zeros or Sanders 2 or 3, and then older than 8 to 9 years old and over 30 kilograms, because smaller than this, it gets a little bit more tricky to do the surgery. But I still tell them that my patients that this is experimental. My optimal indications, maybe closer to 35 to 55. It's less predictable about above 55, but if you have a lot of growth, you can achieve a lot of correction. It's just that it's less predictable that you won't have a second surgery to do this. Premenarchal, absolutely. You want this to be something that they have growth. If they just had their periods, maybe I'll entertain this, but in a smaller curve. And then Sanders 3 and less. I know the indications for the FDA are 3 to 5, but I really like to be under 3 or 3 and less. Open triads is really preferred, but be aware of the very immature patient, especially for smaller curves. If the curve is below 40, you should not do this if the triad is open, and then wait that there's Sanders 3 or 4. You want to prevent overcorrection. If the curve is between 40 and 55, I would jump at the opportunity if the triad is open, but before Sanders 4, it's typically my best indication. Typically, I will tell the patients that there's a slightly higher risk of overcorrection, but it's a good sign if it overcorrects, because then it really worked. And then for curves between 55 and 65, I would only do it if the triad is open and the patient is either Sanders 2 or 3, because then they need to have a lot of growth and they have to expect a higher rate of revision for a broken tether or a fusion. But if you get the right patient and you get them to to go through this, and instead of having a natural history of spinal fusion, you get them early enough, you can probably get them to have a nice correction and over time correct in a nice way. So there's a potential benefit for early treatment. So my take-home messages, and I know I've been a bit long, but VBT in younger children is less predictable, so you have to be aware that this is a higher risk. The growth potential is enormous and can correct significant deformities. I've seen patients with very, very significant curves get a lot of correction through a smaller approach through a VBT. And then the risk of overcorrection or undercorrection is significantly higher in more mature individuals. So you have to be aware that you won't get the same results or the same amount of correction in a more mature patient. So it's really important to tailor your indications based on the timing or the amount of growth remaining. Before I leave you, scoliosis is 3D spinal deformity of unknown etiology. Most patients will show minimal or no progression after maturity. So it's really important to identify patients at risk of progression, and surgery is considered for moderate to severe curves only. And then, yeah, I'll pass it on. Thank you.
Thanks, Stefan. Maybe as Feroz lines up his slides, there's two interesting questions that came up. You know, the ability to control rotation or hypokyphosis with the tethers. So if you could answer those on the chat, that'd be great.
Yeah, perfect. I'll.
Great. Maybe in the interest of time, Stefan, as you answer those on the chat, am I okay to go ahead? Can you guys see my slides?
Yeah, things are looking great. Go ahead.
Yeah.
Okay, perfect. Well, thanks, Jean, for organizing this, and AO for asking me to give this talk. And I was asked to talk about fate of AIS in adulthood. You heard two tremendous speakers and extremely knowledgeable individuals in the area of pediatric deformity. You know, that's where my sort of interest is as well. But I think as pediatric spine surgeons, sometimes depending on your health system and where you work, you kind of lose sight of what happens to these adolescents that eventually, of course, go on to adulthood and what happens to their spinal deformity. So I just wanted to share, more so some of the literature, old and current, and maybe get some discussion going on what actually happens. Now, you heard a lot on different etiologies of scoliosis, et cetera, but this is obviously going to be talking about idiopathic scoliosis and adolescent idiopathic scoliosis in particular. These are my disclosures. And so, you heard this over and over. Jean did an awesome job letting us know that all treatments for scoliosis are really aimed at preventing curve progression. So whether it be benign neglect, and when I say this is you might get serial x-rays, but really even when you're doing that, you're trying to look at whether these patients progress. I mean, we've got some nice numbers and charts, and sometimes it doesn't always work like that. So it's really important that, patients are followed. And right now, we have x-rays, and hopefully in the future we might have something else, but right now we have x-rays to kind of see whether they are progressing, and then you might have to intervene. Bracing, surgery, et cetera, it's all really at preventing curve progression. Even in the tether world, as Stefan did a beautiful job, really the tether will give you some indirect deformity correction, but in essence is acting like an internal brace, and really it is to prevent that deformity from getting any worse. Now, the fundamental question, we have this in the chat as well. One of the somebody asked, how do you define curve progression? And that's an excellent question, because, as a surgeon, we may say, well, it's a change in COB between two serial x-rays, 6 months apart, 4 months apart, or whatever your time interval is going to be. And to, get outside that measurement error, we'll say anywhere between 5 to 7 degrees. But for the patients and families, like if you really ask them, sometimes they care, yeah, they went from 30 to 34 or 36 or something, but they're really in the back of their mind is, am I ever going to need surgery, either in the next handful of years while I'm an adolescent, or even into adulthood? Like if I'm okay now, will I need or should I have surgery now or even later at 25 or 30? So it is really important when we say, what is progression, how we define it, and we speak to our families and counsel them, that they're kind of understanding. Are they really wanting to know what the change in the COB angle is and discuss the x-rays? But if they're really asking about whether they need surgery, then it's very, very important for us as surgeons to understand the natural history. And that's really from their onset as an adolescent, and I would say all the way into adulthood, not sort of at 17 or 18, and now they go into the adult world and we forget about them. But I think it's really, really important that we understand natural history. I'm sure many, if not all of you, are aware that the IO group under Stu Weinstein's leadership, Ignacio Ponsetti, they really are credited for the best follow-up on long-term longitudinal homogeneous cohort of an AIS population, right? So they've done a lot of cross-sectional publications for patients that were treated between 1932 and 1948. So yes, a long time ago. But the beauty of their work is that this was long term, it was longitudinal, and it was a homogeneous patient population. And they were able to really add to our understanding in our literature, and a lot of the items that we use. Stefan showed a nice chart about curve magnitude and how that might dictate what you're going to offer patients. And that really comes from a lot of the work that Stu Weinstein and his group has done in Iowa. They shed light on two things. One is the actual risk of progression into adulthood. This is actually a patient of ours at our center. At 12, she had about a 60-degree curve, was mature, quote unquote, skeletally at the time, but with a 60-degree curve, she was offered surgery, declined, and then they re-presented at the age of 21 with that significant progression. The other thing that the Iowa group also introduced to us is this idea of what would happen, what are the sequelae that many of our patients may face if you leave AIS untreated into adulthood. And so the first paper they came out with was down in 1950. And it's really important because I think we started talking about curve types, right? A thoracic, lumbar, thoracolumbar double major. Now, this is not the terminology that we use these days because we've had different classifications, and of course the most recent is the Lenke classification. But where these curves are, how they behave, their apices and all that comes from the early work from Stu Weinstein way back in 1950. The other important publications that they went through was both at a 24-year and then a 40-year follow-up. So they had 219 patients, untreated AIS. I mean, I'm not sure we would have numbers like that, let alone, as these patients progress, whether we would not intervene. So it would be hard to really, look at a study like this or emulate a study like this now in, 2025 or beyond. Nonetheless, of these 219, 194 patients, and again, these were all seen between 32 and 48, and they evaluated all these patients for things that are important. Metrics like curve progression, back pain, any issues on cardiopulmonary function, their mortality, because there were studies at the time that were saying that with idiopathic scoliosis you might have a higher mortality rate, and we'll talk about that as well. The psychosocial implication or their psychosocial function, as well as pregnancy. So metrics that I think would be very important that patients do raise, even now, in terms of what they might. What scoliosis may, in fact, impact, and what part of their life it's going to have an impact on going down the line. So they shed a good amount of data around this at the 24 and 4-year follow-up. So again, significant period of time for this. What do they find? Well, they said that the curves less than 30 actually didn't progress, and thoracic curves that were over 50, so the ones that were 50 to 75 did progress. And that's where we get our little, maybe 1 to 2 degrees per year. On average, it was about 0.7 per year. Interestingly, lumbar curves that were smaller, anywhere between 30 to 50, actually did progress. And if they're over 50, they progressed at a higher rate. Now, to be honest with you, if I see patients and, they have a curve of their mid-30s and a lumbar spine, I don't give them the same fear that I would say, a thoracic curve over 50, but I would definitely follow them very closely. And I have definitely seen that, after scoliotic maturity, if the lumbar curve was around high 30s, low 40s, they seem to continue to creep up. But, this is, again, all from Stu Weinstein work that actually noted this a while ago for all of us. And the key messages from these two very important papers were that curves actually do progress after skeletal maturity. Now, when we say that, you won't see that rapid rate of progression, some of the stuff that Jean just talked about in terms of, you could add 10 or 20 degrees in a growing child, but we're talking about any progression. And the challenge with late adolescence, early adulthood is if it's a degree or two per year, you really can't tell until a handful of years. That could be measurement error. And because of that, it's really important to have a little bit long-term follow-up data. Back pain, decreased vital capacity, all this they showed was associated with thoracic curve. So really important messages in these two papers that AIS is strictly not limited to your adolescent period, but into adulthood, you can have some sequelae. Now, in 2003, they came up with another landmark paper, a 51-year follow-up. They showed that mortality, there was no evidence of increased rate of mortality. In fact, the probability of survival was almost exactly the same as the general population. But again, other metrics like back pain, it was reported higher, almost double than that in their controls, 61% to 35%. So patients that do have AIS into adulthood that have curves that will progress will complain of more chronic back pain. What about pulmonary symptoms? Well, there was a positive relationship that they noted in their cohort between shortness of breath on exertion and both size and location of the curve. So again, thoracic curve that were larger, these patients complain more of shortness of breath with exertion. And they found that, again, curves greater than 50 were a significant predictor of decreased pulmonary function. So a greater magnitude. Now, the challenge with just looking at pulmonary function for some of these patients, because as we age, your pulmonary function will also be impacted, smoking, et cetera. So there's going to be some environmental factors in it, not simply that they had a curve, but they did note nonetheless in patients that were adults and had larger curves, that was a predictor of a decrease in your pulmonary function. Radiographs, well, again, they continue to show, even at the 51-year follow-up, that thoracic curves that were over 50 did progress. And at skeletal maturity, they noted that patients in their sort of late adolescence, early adulthood didn't have much OA, but at the 50-year follow-up, many patients had developed osteoarthritis of their spine. Cosmesis, another significant concern in this cohort. They were less satisfied with their appearance than the controls. And I think nowadays, what I found, at least in the last probably decade or so, is that this is a significant concern for adolescents as well in their appearance and the way they look. Of course, it is it's a cosmetic deformity, and I think we are addressing that. I mean, we have to balance that between lengthening the spinal cord and issues with intraoperative monitoring, et cetera. But nonetheless, I mean, this is a real significant impact for patients as they navigate life with a significant curve to their spine. Now, what about current literature? And so the current literature, I kind of broke it up in three things, right? Health-related quality of life in untreated IS. And is there anything newer than what Stu Weinstein, et cetera, have done in the past? Their 51-year follow-up came out way back in 2003. Next was surgical outcomes in AIS versus adults. Is it better to treat them early versus late? And then are there any long-term health-related quality of life studies following patients that have had surgery as adolescents into their adulthood? So is it the right thing to do as well? Now, Mike Gershon and Benny Dull in the Netherlands recently published this about a year ago, and this was specifically looking at health-related quality of life. They had a 40-year follow-up, 73 patients. Some of them were braced, some of them were observed, but none of them had surgery. And they did find that these patients had a lower health-related quality of life compared to their age-match controls and a higher rate of incapacity to work. So again, untreated AIS into adulthood had a significant impact on health-related quality of life, at least in the Netherlands. Very similar and in keeping with the work out of Iowa. Noah Larson looked at their experience at the Mayo Clinic. She found 32 untreated AIS patients. Minimum follow-up was 20 years, so again, a fairly lengthy follow-up. And all these patients also had lower SRS and SF36 scores compared to the age-matched control. So these studies are actually giving us a bit of a common theme. And in fact, in Noel's study, 20% actually went on to have surgery at a later time, but nonetheless, they were untreated AIS and decided to have a surgical intervention later. Now, what about surgical outcomes in AIS versus adults? So if you had a patient that had idiopathic scoliosis as an adolescent, should they have surgery now versus later? And do we have any data around that? So there's been a number of studies. Some have been systematic reviews. And, for my adult colleagues out there, I feel your pain. There's no question that, unfortunately, the complication rate, both number and type, is far greater in adults than in adolescents. And of course, we have comorbidities that can set in, et cetera. So that is something to take into consideration. These other studies have also shown, this was a nice study looking at the survival of 517 cases over 25 years, and the revision rates were 13% at 5 years, 18% at 10, and 20% at 15. So the longer you wait, unfortunately, the higher revision you had, and there was a strong association with age. These two studies also highlighted that you get better curve correction if the surgery was done earlier as an idiopathic scoliosis, because the adult patients had bigger and stiffer curves. So much of our literature is suggesting that, in adolescents, considering surgery, of course, if curves are 50 or more, may be a little bit better because that perioperative hit is a lot less. We looked at this through the harm study group as well, and Baron Launer led the way in this. 28 adult patients, we matched them 1 to 2 to 56 AIS patients, and again found that the perioperative insult in AIS was better. We had shorter fusions, less estimated blood loss, shorter OR time, like the hospital stay, as well as minor and major complications. We had a greater improvement, surprisingly, in the adult in terms of quality of life, but you have to qualify this, right? Because these adults, they started lower due to that negative impact of the natural history of their untreated AIS. So they were not happy as they continue to navigate life, and then they had their operation. So they already started with lower scores, so that delta was going to be a little bit better. But the perioperative insult was far better in adolescents than it is in adults. Now, what about long-term effects of health-related quality of life following surgery, and is there any data around that? So the short answer is, unfortunately, there's not much. Our Asia Pacific colleagues, had this study published about a year ago. 179 surgical patients. They had very variable follow-up, and they found relatively good quality of life in the cohort, and these were treated between 68 to 82. So pretty, a fairly old cohort, and probably underwent fusions, et cetera, very different than what we do now, but still shed light that these patients that had surgery even so long ago were still we're still happy with their result. This was another excellent study done by our Spanish colleagues, and this was more of a qualitative study. They looked at identifying their patients. They had pretty old instrumentation, a CD Horizon, sort of in the 80s and that. And 30 years later, how did they bode? And they actually interviewed some of these patients and shared their thoughts and published this paper. And some of the patients were quoted as saying surgery was a liberation. They felt much better than family members that unfortunately did not undergo surgery when they had the chance. So suggesting that those patients, for the right indications, that were operated on as adolescents into adulthood, seem to be happy with their fusion, or seem to be happy with the decision to go ahead with surgery as an adolescent. So in summary, I'd say that there is very good evidence that despite skeletal maturity, depending on the magnitude and location of curve, that they will progress. The risk of back pain, functional disability like PFTs, and the disfiguring effects of the deformity are very real. And that's why that 50-degree rule for thoracic curves has been established as a discussion point with family members and the patients to consider surgery. It does appear that in adolescents, the perioperative course is better than in adults. But I would qualify that is we really don't have great literature that's comparing AIS fusions versus non-operative management for that same cohort into adulthood, right? So if a curve was, say, in the low 50s and they stayed like that, as a 50-year-old, is that better than somebody having a straighter fused spine, as a 50-year-old? We really don't have that comparative study, but hopefully from what I presented, you get an idea of what happens to the idiopathic scoliosis in adulthood, and helps you with decision making with the patients, because I do find that patients are coming in asking a lot about the long-term effects, both of surgery as well as not having surgery right now. Thank you very much. And I just want to put a plug in for the Harm Study Group 30-year gala that's coming up in March. And we've got a great pediatric small deformity course organized then as well, and happy to entertain any questions.
Yeah, so fantastic talk. Thank you so much, Stefan and Feroz. we're really at 1 minute mark. So as predicted, we all like to talk, and obviously we're very passionate about this. Any
Some more than others, huh?
what's that?
Some more than others.
Yeah.
Sorry.
But that being said, I think we managed to touch, and I hope all of you, it's great that we had 88 participant this morning and this evening, and that and they stuck throughout the whole talk. So I guess that we had something to say that people appreciated. Just a reminder for your CME, you'll be getting an email to go ahead. I think that I'm still learning, and I definitely enjoy being involved in the AO. This is a great way to stay up to date, keep challenging us. I think the reality is that we're still, bottom line is we're still trying to figure out what's the best for our patients. And the only way that we'll improve is really sharing our experience and getting our patients' feedback and so on. So I really thank all of you to come and join us. And hopefully we'll be having a few more webinars on pediatric deformity. So on that note, I don't know if my faculty have anything to add or say, but I wanted to thank you for, again, putting your time and energy to give us great talks. Thank you.
Thanks, John. Great organization. It was a pleasure to be involved. Always learning something from both of you guys. Thank you.
Yeah, same here. Was nice.